3 years ago, in April 2023, I informed the House that Singapore will become a super-aged society in 2026. This year, this is when 21% or more of our population will be 65 and above. So you consider in June 2025 last year, already 20.7% of our population was 65 and above. And that percentage has been going up by about 1 percentage point every year. So we should have crossed 21% by now. So as I speak, Singapore is a super-aged society. So welcome to super-aged Singapore. When was the exact point of transition? Actually, I don't think anybody knows. We can do an estimation. What happened at the exact moment? Nothing dramatic. There wasn't a SCDF siren or anything. It came and gone. Aging does not arrive with a bang. Neither is it a whimper. It progresses quietly with a real and profound impact. And at MOH, we feel it very strongly in the hospitals, in the emergency department, in nursing homes, and we are doing our best to manage the workload and care for all our patients. More importantly, we foresaw this demographic transition years ago and took as many early action as we can. This includes raising the GST to strengthen our fiscal position, increase the retirement and re-employment ages, build many more age-friendly streets and two-room flexi and senior apartments, bolstered financial security for seniors through Silver Support, CPF Life, MediShield Life. And these policies are long in the making. They have helped cushion the impact of this very profound demographic transition. But arguably the most complex task is to prepare for an older population is to sustain and to transform the healthcare system. These are the two topics I want to talk about today, sustain and transform. Let me first touch on sustaining the healthcare system. Rising demand and care means the healthcare system must expand. It will become bigger, which we are doing. At the opening of this term of Parliament, the MOH addendum set out the target of adding 2,800 more public acute and community hospital beds between 2025 and 2030. We are on track. However, meeting rising demand and running a larger system will cost more. And if we do not manage this carefully, rising healthcare spending can strain public finances and household budgets alike. In fact, if we are really extravagant, we are not careful about it, it can even cripple our system. How do we ensure healthcare remains affordable? I think we need to start at the very top to ensure that the national healthcare bill is under control. Otherwise, it's like the Titanic sinking and you are pouring water out of the deck. It must be floating. National healthcare expenditure, and that is the hospital bill of the nation. And that bill, remember this, is always and is ultimately paid by the people, whether through healthcare charges, through taxes, through insurance premiums, through medical security contributions, ultimately is always paid by the people. So a government can claim we provide cheap or even free healthcare. It's actually not very true. The truth is healthcare is never really free. Even if patients do not pay anything at the point of delivery, they will just pay in some other ways. A sick nation that consumes healthcare indiscriminately will incur a large and wasteful bill, and it will be very costly to the population, to the households, to the patients, to the people. So with your permission, Mr. Chairman, may I display a couple of slides on screens, please? Go ahead. Thank you. This is a scatter chart, different countries, and you can see Singapore is an outlier in the bottom right corner. Let me interpret this chart. The vertical axis measures how much the population spends on healthcare. Developed economies, shown by the different dots on screen, typically spend about 9 to 12% of GDP on healthcare, with the US outlier in the other direction spending 17%. Singapore spends below 5%. The horizontal axis is average lifespan. This is an internationally accepted and generic measure of health outcomes. And Singapore has one of the highest lifespans in the world. But of course, beyond lifespan, there are many other measures of health outcomes. And across all these measures, Singapore are comparable or even better than many developed economies. So how did we become an outlier like this? I think it has a lot to do with our S+3M healthcare financing system that members are familiar with. And MediSave is the linchpin of that system. Singaporeans and our employers set aside part of our monthly income into MediSave. The government also provides top-ups from time to time for various segments of the population, and we did that again this budget. And we then use MediSave to co-pay directly for a small part for the cost of healthcare. So even a modest co-payment, it goes a long way to instill discipline and reduce unnecessary consumption on both the supply as well as the demand sides. And we do not have to look very far to imagine what happened when that discipline is eroded. You just look at private healthcare in Singapore. The discipline of co-payment was weakened because of overly generous insurance, including the IP riders. And as a result, private hospital bill sizes have been rising rapidly. Private insurance premiums have been escalating very quickly. So once that genie is out of the bottle, it is difficult to put it back. But we will try. It will not stop us from trying. In our S+3M system, multiple payers, they pull their weight to pay for this national healthcare bill. Apart from co-payment, we have insurance schemes like MediShield Life. It plays a sizable role. A big part of it is also paid by charity dollars. We thank all the donors and philanthropic organizations. But the biggest proportion, about half, of the national healthcare bill is paid through tax revenues, redistributed as government healthcare subsidies. The government health budget today is about 2.7% of GDP this year. And it is expected to rise to about 3.5% GDP by 2030. This 0.8 percentage point increase is actually very significant. It means increasing government health budget from about 22.5 billion this year to about 30 billion by 2030, or in 2030. And beyond 2030, the government health budget will likely continue to grow. And we must ensure that the increase can be supported by economic growth and by rising tax revenues. And at the same time, we must continue to maintain that discipline and avoid unsustainable level of healthcare spending that we see elsewhere. So the next topic I want to talk about is to transform the healthcare system. A healthcare system for a young population is very different from one for an older population, for a super aged society. Because you imagine for a young person, sickness tend to be episodic. You are admitted to hospital, you got treatment, you get discharged, and then you recover. Good health is the default. On the other hand, an older person's care journey is complicated and continuous. When well, they need preventive care. When sick, they need coordinated care because they tend to have multiple conditions. Post-discharge, they need rehabilitative care and follow-up care in a community. Good health is not a default, it's a continuous quest for an old person. So from episodic hospital care, we now need continuous multidisciplinary care across settings. And this shift is reflected in how we have allocated healthcare funding over time. Let me show another chart on the screen. Left chart is the height of the chart is our government healthcare budget, 2021. Right bar is 2024. You can see that overall budget has increased by 1.5 times. But I want to draw members' attention to the composition. At the start of this decade, 2021, about 3/4 of our operational funding for the healthcare sector went towards acute hospital care. That's the white portion of the bar. The remaining 1/4 was spent on aged care and population health, including preventive and primary care. Today, we move to the right, 2024, the budget is 1.5 times higher, but the share of acute hospital care has fallen from 3/4 to almost 2/3, and the remaining 1/3 goes to aged care and population health. Specifically, the share of funding for aged care rose from 11% to 13%, that's the green portion, between 2021 and 2024. And over the same period, the share for population health grew from 14% to 19%. And these shifts are largely driven by our national programs, Healthier SG and Age Well SG. And looking ahead, how would this chart go? I think almost certainly the share of spending on aged care will grow further because we need more nursing homes, senior care centers, rehab services, hospice care. As for population health, we do our best to maintain this share at around 19%. With total spending rising, maintaining the share alone requires a strong commitment to continue to invest in population health. Mr. Chairman, today my MOH colleagues and I will be speaking on further steps to transform healthcare and get ready for the future. SMS Co will speak about manpower. It is a key agenda, including how we will significantly shorten the time to train clinical psychologists. We are taking 7 to 8 years currently. We will reduce it to about 5 years. SMS Tan will speak about anchoring care in the community through technology. And you heard MOS Rohayu speaking about population health and preventive care, including what we are doing in the north, where prevalence of chronic diseases are higher. There was a question by Ms. Mariam Jaafar. You missed that part of the speech. Yeah. I should emphasize, this is in case she asks many clarifications later. I should emphasize, preventive care and population health remain the overarching strategic thrust of what we are doing, anchored by Healthier SG and Age Well SG. I thank Ms. Mariam Jaafar, Dr. Haresh, for speaking about this. This is at the core of healthcare transformation, and MOH agrees with many of the points you have raised. I will now speak about 3 new initiatives to support healthcare transformation. The first common topic, this whole COS and budget debate, AI once again. Ms. Mariam Jaafar and Dr. Chu Pei-Ling spoke about how AI can strengthen healthcare delivery, and we agree. So when it comes to AI in healthcare, we are guided by 2 principles. Number 1, care should be AI enhanced, not AI decided. Clinicians remain in the loop, and healthcare remains a profoundly human endeavor. Number 2, we take a practical use case approach. AI should not be a hammer looking for a nail, a solution looking for a problem. We deploy AI where we know it will improve patient outcomes or the delivery of care, and it can do so cost effectively. And one such use case is in health screening. Around the world, many AI models have been trained to predict if a well person is likely to develop severe diseases in the near future. And if you use it appropriately and responsibly, such tools are very useful. It helps the clinicians intervene early. It can delay or even prevent the onset of serious diseases. MOH has developed such a model for our local context using anonymized patient data. With this model, by reviewing an individual's current health status, it can identify if he has a high risk defined by 75% or above, of developing chronic diseases such as diabetes or high cholesterol within the next 3 years. We chose diabetes and high cholesterol because they are the key drivers of strokes and heart attacks, which affect 60 Singaporeans every day. Every day, 60 Singaporeans either have a heart attack or stroke. Many of these cases can be prevented if early actions were taken, such as through lifestyle adjustments and medication. This AI risk assessment tool will be rolled out to doctors for all Healthier SG enrollees from early 2027. If the tool flags a patient as high risk, the doctors may recommend more significant lifestyle adjustments, and instead of three yearly checkups, maybe annual checkups. And these additional screenings will continue to be subsidized under Healthier SG. The second initiative, I think, is an exciting and significant one, and a breakthrough, which is to use genomics to strengthen preventive care. Dr. Hamid Razak asked about this. We are born with our genes. They shape our biological blueprint, and indeed, many diseases are linked to our genetic characteristics. But we need not be fatalistic about it. Genes are not our destiny. How we live, how we manage risk matters a lot. So we do not go fumbling through our genetic blueprint, hunting for blemishes and possible mutations that we know little about. It will create a lot of anxiety, and all of us will become a nation of hypochondriacs. So instead of shooting in the dark, we should focus on the parts of the blueprints that are illuminated by science. This means taking a disease-specific approach, identifying genetic characteristics that we know drive certain diseases, and for which we know there are established preventive interventions and treatment pathways. And this is what we did for FH, familial hypercholesterolemia. And that we did that last year. And FH is a genetic condition that increases the risk of heart attacks, even amongst young people. The FH genetic testing program offers subsidized genetic testing for individuals with abnormally high cholesterol levels. And if they are tested positive, we will offer the same test to their immediate family members. This is what we call cascade testing. And by doing so, we try to identify as many individuals as we can in Singapore with the FH genetic mutation. And then we take steps to reduce their risk of future heart attacks and strokes. And we will now move on to our next genetic condition, which is HBOC, hereditary breast and ovarian cancer. In Singapore, it is estimated that 1 in 150 individuals carry a mutation in genes, such as the BRCA1 or BRCA2, that are associated with HBOC. Such a mutation substantially increases a woman's lifetime risk of developing breast and ovarian cancer. From December this year, we will offer subsidized genetic testing to at-risk individuals for HBOC, such as individuals with a family history of HBOC or breast and ovarian cancer. They will undergo genetic counseling before and after the test, and if they test positive, we will also offer the test to their immediate family members, cascade testing. We expect over 2,000 individuals to be eligible for the test annually. We will make the test affordable. In addition to subsidies, the cost of the test can also be offset using MediSave. For those found to have the mutation, they will be offered suitable preventive interventions. Typically, this means more frequent breast MRIs or mammograms or oral medication. Patients will ultimately decide, in consultation with their doctors, which intervention is appropriate. A minority may opt for surgical interventions. Members may recall celebrity actress Angelina Jolie. After she discovered she had the BRCA1 gene mutation, she underwent a double preventive mastectomy. I came across women in Singapore who chose to undergo preventive mastectomy to reduce their risk of breast cancer, such as Ms. Gwendolyn To. And these women have demonstrated great courage. Unfortunately, they lament that they cannot claim insurance for such surgeries because MediShield Life generally does not cover prevention. And it is designed to be so for a good reason. It is to keep coverage focused and premiums affordable. Then private insurance take dressing from MediShield Life. Dr. Hamid Razak and Ms. Sylvia Lim asked about this. In fact, Ms. Stephanie Teo, she's the founder of the non-profit organization She, SG Her Empowerment, has raised this issue with me several times. I share your concerns. With advances in medical science, the boundary between preventive and curative care is increasingly blurred. If a high-risk individual is unable to undergo preventive mastectomy, she has a high chance of eventually needing cancer treatments, including a curative mastectomy to remove cancerous cells in her breast or cancerous tissue in her breast. There is hence a case for MediShield Life to be judiciously extended to cover certain selected preventive surgeries. We are prepared to do so when there's a clear clinical need, minimal risk of abuse, the procedure is suitable for risk pooling through insurance, and it does not financially burden the MediShield Life scheme. Risk-reducing mastectomies for breast cancer prevention and the removal of both fallopian tubes and ovaries for ovarian cancer prevention fall within these criteria. We will therefore extend MediShield Life and MediSave to cover preventive surgeries for HPOC later this year. I should add that breast reconstruction is also covered, no different from today. This will better support women to harness genomics to better take care of their health. I think this is a meaningful policy change ahead of International Women's Day on the 8th of March. The third initiative is to inject more flexibility in the use of MediSave to encourage early intervention and reduce downstream complications. Associate Professor James Lim was right to describe medical expenses as lumpy. Indeed, it is very well documented that hospital expenses escalate almost like a vertical wall towards the end of life. And so even after accounting for inflation, the average Singaporean living up to their mid-80s spends almost 4 times as much on hospital expenses in the last 10 years of their life compared to the previous 10 years. But that explains the existing design of the MediSave withdrawal system and why the system is designed like that, why the scheme is designed like that. It has higher limits for more complex treatments and longer hospital stays, and you can draw on it as and when you need it. This meets the original objective of MediSave, which is to co-pay for major inpatient episodes, whether they happen unexpectedly or in old age. With this design, after subsidies, MediShield Life and MediSave, 9 in 10 Singaporeans pay less than $500 out of pocket for their subsidized inpatient bills. However, it is human nature to worry about present medical expenses rather than lumpy potential unexpected or future hospital bills. Hence, as a relief valve, we have schemes like Flexi MediSave and MediSave 500-700 to provide flexibility for chronic disease management, for scans, for dentist visits, etc., without overly diluting MediSave's original objective of catering for these big, lumpy hospital bills in old age or during emergencies. But the situation has changed since MediSave was implemented in 1984. At that time, people in Singapore lived to about 73 on average. Today, we live to 85 and beyond. On one hand, it continues to be important to preserve MediSave for big hospital bills. On the other hand, as people live longer, the need to spend on preventive care and chronic disease management also go up. Hence, I can appreciate the repeated and various calls by members to allow MediSave to be used more flexibly to cover more chronic diseases, or as Mr. Pritam Singh suggested, to pay for higher private insurance premiums. But I also hold the realistic view that no matter how frequently MOH reviews the MediSave scheme, how much we liberalize and expand its usage, The public and members of this House will continue to press me and MOH to liberalize the scheme every year during the COS and probably outside of the COS. It is the karma of this scheme, because it is designed to be the linchpin of the healthcare financing system. It must always navigate between present and future healthcare needs, between recurring disease management and the major hospitalization episodes. Trade-offs are inherent in the MediSave scheme. It is zero-sum. Using more balances for recurrent medical expenses means having less in the future when we are hospitalized, and vice versa. And when the tension becomes too severe, we will have to consider raising contribution rates so that you have a bigger pot to spend. The tension is therefore deliberate and a design feature. It is a balance we must constantly and carefully manage to ensure the system of co-payment is held together while ensuring affordability and keeping CPF contribution rates reasonable for everybody. Hence, we continue to have ongoing regular reviews to study where we can expand the use of MediSave and provide more flexible withdrawals. For example, we recently increased the Flexi MediSave limit for seniors, and we doubled the annual limit for diagnostic scans. This time, we will make further changes to the MediSave 500-700 scheme. This scheme helps patients pay for the recurring costs of managing conditions on the Chronic Disease Management Program, or CDMP. Mr. Chai Ying-zhou, Mr. Gerald Giam asked about this. So today, individuals with a simple chronic condition can use up to $500 a year, while those with complex chronic conditions can withdraw up to $700 per year. To provide more support for preventive and chronic care in the community, we will raise MediSave limits from $500, $700 to $700, $1,000. This will benefit over 910,000 patients who currently tap on the scheme, roughly 20% of whom have annual bills exceeding the withdrawal limit. We will also expand the list of conditions covered under the CDMP to include hyperthyroidism and hypothyroidism. In addition, we are studying whether we can include other chronic conditions such as eczema in the CDMP. With the above enhancements, we will rename MediSave 500-700. It's actually a cumbersome name. Every time you change the limit, you change the name. We will rename it to MediSave Chronic and Preventive Care Scheme to reflect the scope of coverage. The changes will be effective January 2027. Before I end this section, let me address the question posed by Ms. Sylvia Lim. Ms. Lim, I thank her for watching my TikTok videos. She mentioned the role of riders in providing additional coverage for cancer patients not on the cancer drug list. The objective of the recent changes to the IP riders is to prevent the over-erosion of co-payment, because that sets off a buffet syndrome, and then that leads to rapid escalation of private hospital bills. IP riders covering non-CDL drugs for outpatient treatment do not contribute to this erosion, and therefore this feature will not be affected by the changes. I should also point out that the changes to IP riders affect only new policyholders, but not existing policyholders. We will always watch out for the cancer patient when we make changes to IP riders. Mr. Chairman, when I informed the House 3 years ago that we'll be a super-aged society this year, it was not to instill fear, but to prepare ourselves. Our transition to a super-aged society has been steady rather than dramatic. It reflects deliberate, long-term planning, including transforming the healthcare system. Indeed, healthcare transformation is fundamentally a long-term endeavor, not one sweeping reform. It is the accumulation of numerous small steps, each taken with judgment and purpose, each carefully planned and executed, and today we announced further deliberate steps. Mr. Chairman, it is my hope that this House continues to support our approach of long-term planning, long-term governance, to anticipate future challenges early and act before they overwhelm us. If we do so, we need not fear being a super-aged society. We can embrace it, and we can make the best of it. Ultimately, it is not the percentage of Singaporeans above 65 that defines us. We can exercise our wiser minds to mourn less for what age takes away from us than what it leaves behind. What matters is that Singaporeans are not just living for longer. We are living healthier for longer. We are not just a super-aged society, but we are striving to be a super healthy one as well.